This is Rural Health Leadership Radio.
Episode 181, a conversation with Dr. Dan Doyle, a family physician who wears many hats in West Virginia.
To deliver the things that we want to deliver to people, everybody has to have access to care, and that includes healthcare coverage.
Welcome to the Rural Health Leadership Radio with your host, Dr. Bill Oxier. Each week, Dr. Oxier has a conversation with a different rural health leader to discuss what's working and what's not working in rural health, along with other topics of interest to rural health leaders. Rural Health Leadership Radio's goal is to improve health in rural America by providing a simple, no-cost means to share information and connect rural health leaders from around the country. And now, here's Dr. Oxier with today's guest.
Hi, everybody. I am your host, Dr. Bill Oxier, and welcome to the Rural Health Leadership Radio podcast. January is flying by, and I hope your plans are in place for an incredible year. You know, my coaching team and I are looking to add 2 new clients in the first quarter of the year for the Quality Operational Financial Leadership Project for Rural Health. This team coaching program is designed to help your hospital or clinic go from good to extraordinary. This program has a tremendous impact on organizational culture, employee engagement, cash flow, and profitability, is much, much more. So if you're curious, just send an email to me to bill@billoxier.com and we'll schedule a free discovery call. Today, I'm excited for our guest to share information with you to assist rural health leaders with best practices as it relates to chronic disease management, COPD, in particular. Now, this interview took place a few months ago as episode 3 of a 7-episode series that the National Rural Health Resource Center put together for chronic disease management. And I want to thank them for allowing me to be a part of that and for making today's episode possible. So now on to today's guest. Today we're having a conversation with Dr. Dan Doyle, a true rural health leader who wears many hats. Dr. Doyle is a physician at New River Health Association, a federally qualified community health center in West Virginia. He's a physician and consultant at Cabin Creek Health Center, another FQHC in West Virginia, medical director of New River Breathing Center, a black lung clinic, which is part of the West Virginia and Federal Black Lung Clinics program. And since 2013, Dr. Doyle has been the medical director of the Grace Ann Dorney Pulmonary Rehabilitation Project of West Virginia, which is a collaborative effort of Cabin Creek Health System FQHC, New River Health Association FQHC, Southern West Virginia Health System FQHC, West Caldwell County FQHC in North Carolina, Boone Memorial Hospital, and Jackson General Hospital, providing community-based pulmonary rehabilitation services. You must have a large closet to fit all those hats in, Dr. Doyle, but welcome to the Rural COPD podcast.
Thanks, Bill. It's great to be here.
So tell us about yourself. Who is Dr. Dan Doyle? What is your story?
Well, my story is that I grew up in northern Indiana, went to University of Notre Dame as a liberal arts major, decided I wanted to go to medical school, and in 1968 came to Harvard Medical School. Took 2 years off in the middle to work as a community organizer and health educator in inner city neighborhood of Boston called Roxbury Mission Hill. Came back to medical school, finished in 1974, did a family medicine residency at UMass Worcester. And at the end of that time, my wife and I were looking for a place, needed to get a job. I had some loans to pay off, nothing like the graduates do now, fortunately. So we looked around the country. I knew that I was interested in a community health center, having had some exposure to that during residency. And also, I knew I didn't want to wind up on the East Coast or the West Coast. I came from the Midwest. There's a brain drain or a doctor drain to the East Coast and West Coast. So I was looking for an underserved community and found kind of the ideal situation, we thought, in West Virginia, where the United Mine Workers Union and the UMWA Health and Retirement Funds were helping underserved communities start their own community health centers with community boards of directors made up of mine workers and family members of mine workers unions. That sounded interesting to me. We came there in October 1977 to New River Health in Fayette County, West Virginia, and we've been there ever since.
Wow, that's impressive that you've been there that long. So what were the key factors of you choosing that location, in addition to what you just shared with us?
I would say key factors is that we were hikers and backpackers, and we had been to West Virginia, so we knew how beautiful it is.
Yeah.
Another reason is that we knew a little bit about the economics of West Virginia and the communities, and we felt that if you wanted to serve an underserved community, this was a good place to be.
Yes, yes.
I was also really impressed by the fact that the mine workers were organizing themselves to provide health care, a big issue in the mid and late 60s in West Virginia, especially, and the surrounding region, had been a movement for miners to be able to get federal black lung benefits, compensation for coal workers' pneumoconiosis. And really, these health centers were coming out of that movement. So those things all sounded attractive to me. Another thing was that it was an opportunity to start something new. There wasn't any health center yet.
Right. Yeah.
And I paired up with a mine worker organizer named Craig Robinson, and he was working with different community groups who were trying to get started, and a big challenge for them was to find doctors. So
Right.
I thought it would be exciting to be in on the ground floor starting something new, and so that was a challenge and an attraction for me also.
Yeah, sounds interesting. I'm sure there's a lot more stories I'd love to talk to you about in that quest of the 41 years that you have occurred since you'd made that big decision. But today we're here to talk about COPD. So why are you here with us today talking about COPD?
Yes, we're here to talk about COPD, and in particular, I'd say we're here to talk about the disparity between the impact of COPD on, or the excessive impact of COPD on rural communities compared to urban. And then in addition, some of the work that we've done over the past 5-6 years trying to bring pulmonary rehabilitation to rural areas, in particular rural areas of this region of our country. So naturally, over the years, as a family physician, I was involved in COPD all the time because it's the fourth leading cause of mortality in the United States, and it just so happens that Kentucky and West Virginia have the leading prevalence of COPD in all 50 states in the country. So we were right in the middle of it from the start, and we were also in the middle of taking care of people with black lung and trying to learn about how you diagnose and treat that, which I never got in medical school or residency.
Mm-hmm.
But I want to just step back for a minute and say that my larger perspective is that I'm a primary care physician, and COPD was one of many things. So my biggest concern, and always our biggest obligation and mission, has been to provide access to care for people in our communities. Access to care for everybody is the number one mission of any FQHC and primary care provider. And then in the last 10 or 15 years, there's been a much greater emphasis on chronic disease care. And so all along, it's been trying to provide excellent medical home, chronic disease care. And what really stands out, from a lot of energy has gone into diabetes care and organizing for that. Certainly energy around cardiovascular disease and cancer. Sometimes COPD seems like it gets left out. Grace Andorni frequently talks about the fact that the CDC has no budget for COPD research, and that's one of her causes that she's thought about. So I would say that for me, COPD was one of a number of chronic diseases I was interested in until 2012, when Ted Koppel and Grace Andorni showed up in West Virginia and said, we want to make pulmonary rehabilitation available to people in rural communities. Will you work with us to do that? And Craig Robinson and I and several other people that he brought together, rural hospital administrators, CAMC, which is our big tertiary care hospital in Charleston, responded to their challenge and said, we'll do that. And so I got involved in pulmonary rehabilitation beginning in late 2013. And I have worked on that project ever since. And it's been a big education for me. It's been an exciting project. I really loved seeing how the patients respond, something they never had before. So over these and in the beginning, I had to learn about pulmonary rehabilitation because it wasn't available. So I wasn't referring people for it. And I wasn't even sure how much benefit it would be, but I got educated about that. And so I've kind of joined them in the cause of campaigning for it.
Yeah, it sounds like the Dorney Koppel Foundation, with the leadership they provided, swung a huge door open for greater access to care for those COPD patients. So that's cool for the leadership they've provided there. Can you talk about early diagnosis of COPD?
Yes, and maybe even a little bit longer list than that. But some of the things that have been important as we have worked with this group of 9 organizations, 8 in West Virginia, or 7 in West Virginia, 1 in Western North Carolina that you mentioned, and also 1 in Eastern Kentucky, is coming up with a coordinated and better approach to COPD. And we've received a lot of help in that from the COPD National Action Plan that was put together and published by NIH in 2018. And they definitely emphasize the need for earlier diagnosis of COPD. We know that there's 16 million people in the country diagnosed with COPD, but we also know that there's at least that many again who are undiagnosed. So a big emphasis, and definitely Grace Andorni brought this to us in 2013, is the importance of making pulmonary function testing available to people. It has not been that available, especially in rural areas and in primary care areas. So we need to provide pulmonary function testing to people. We need to get doctors and providers to order it because it's very common still to find people who are on 2 or 3 inhalers and have never had a pulmonary function test. So there's a big emphasis on providing the testing, but that's not really enough because we need to think about COPD when we're seeing people in the earlier stages. Somebody who's smoked for 20 years, somebody who's coughed, somebody who's getting short of breath. Frequently, we will treat people for bronchitis 2 or 3 or 8 times over 2 years before it finally dawns on us, hey, this person might have COPD, we need to test them, and we're trying to get that delay down. And the first 1 or 2 episodes of bronchitis in the smoker who's in their late 30s, early 40s should be tested. So early diagnosis, earlier diagnosis, and correcting the gap in diagnosis is a big priority.
Yeah, it's interesting that you said, your number one objective as a physician is access to care. And when you really started drilling down on COPD, you realized that you had a lot to learn about that. And that's something that you've been sharing with us right now about. There's a lot to learn about caring for this disease. I mean, how does a rural physician get through that learning curve? How do they learn more like you've done?
Yes, and I had a lot to learn 35 years in, and no surprise, we keep learning important things every day. Sometimes something I'm embarrassed at till I kind of realize it's normal is how many important things I learn each day, or at least one every day, that I should have known 20 years ago. And that certainly has applied to COPD. And an issue actually with COPD education is that often the hospital provided, the county medical society, the state medical society provided continuing medical education. Often, the overwhelming majority is funded by pharmaceutical companies. And so very often the education is heavily weighted on the side of the latest drug, the newest drug, how to use these drugs. And there's a whole other, and not on pulmonary rehabilitation and its value, because it's not profitable, it's not a drug. not on earlier diagnosis, not on accurate interpretation of spirometry. So how do we get that message to primary care physicians? And that's a big concern of mine. I know it's a big concern of the Grace Ann Dorney Pulmonary Rehabilitation Centers as a group. I know it's a big concern of the NIH, the National Institutes of Health, Heart, Lung, Blood Institute. It's something that's featured in the COPD National Action Plan. But how do we do it? I think one way is as practices and as leaders trying to organize the education within our own practices, making sure that we're bringing the guidelines to people, like the GOLD guidelines, which is the Global Obstructive Lung Disease Guidelines. There's a great set of guidelines that comes from the American Thoracic Society. So it's getting within our own environments and practices and hospital staffs and county medical societies and state family medicine conferences, getting those guidelines up for discussion. Another thing is to organize our practices so those guidelines are actually put into practice, and continued self-study and making each other aware, I think, are some of the ways.
You mentioned something about spirometry. Can you talk about what is quality assured spirometry and what does that mean to rural health?
So I got that term quality assured spirometry from UK literature about COPD and pulmonary rehabilitation. We, in my practice at New River Health, we had been saying NIOSH certified because spirometry, which is almost synonymous with pulmonary function testing. Sometimes we use pulmonary function testing to refer to a broader set of tests than simply the blowing in the tube test.
Okay.
It includes lung volumes and DLCO, but spirometry, which is the main test for diagnosing COPD, like a blood pressure cuff is for high blood pressure, or like a A1C or blood sugar test is for diabetes. It's the test, the gold standard test. So spirometry, however, is much more dependent on the technician doing the test and his or her skill and experience than, say, doing an EKG or even doing an X-ray. It really depends on somebody knowing what's a valid test, coaching the patient, preparing the patient. So there are courses, and National Institutes of Occupational Safety and Health has a certification program. And so having people doing the tests who have gone through those courses to make sure you get accurate testing is a significant challenge. And so within our group of 9 Grace Ann Dorney Pulmonary Rehabilitation Centers here in Central Appalachia, and I know they have 2 other centers too, one in Maryland and one in New Orleans, Louisiana. I know that those hospital sites have certified respiratory therapists doing spirometry, but frequently in the primary care test setting, we've had either no spirometry, which is the most common, or a practice will buy a handheld spirometer and sort of hand it to the nurse and say, read the instructions and do this. And that is not good enough. People really need to have more training to get accurate results.
Interesting. That sounds like a challenge in and of itself right there.
It is.
Yeah. So, you've mentioned Grace Ann Dorney Koppel a few times here. I had the honor of interviewing her a few episodes ago on COPD, and I was shocked when she said that 25% of the people diagnosed with COPD are non-smokers. Can you talk about the relationship of smoking and COPD?
Sure. The figure tends to be either 25 to 30% of people with COPD, defined as having a quality assured breathing test showing that you are unable to get out more than 70% of your total breath in 1 second. That's essentially the definition, that when you take a great big breath and blow it out fast into the machine, you're supposed to be able to get more than 70% of all your breath out in 1 second or less.
Okay.
So that people who have COPD, 25 to 30% of them have never smoked. So what we know from that is a very significant percentage of them have occupational exposures or environmental exposures that are known to cause obstruction. Coal dust is a great example of that. There's other kind of dust lung disease, occupational dust lung disease. It's called pneumoconioses that do that. It's also true that that around the country, especially in third world countries, where women are cooking food or heating with biomass, which essentially means cow patties or buffalo patties.
Yes.
They get significant smoke inhalation. That's a significant cause worldwide, also of obstructive lung disease. But some of those are also preventable, and we're right in the epicenter of one of those, black lung coworkers pneumoconiosis here. But we can't directly affect the coal dust environment and the coal dust enforcement in the mines and around the mines. We have to be aware of that. We have to ask about it, consider it, and as citizen activists, we have to do what we can to support the mine workers' struggle for a safer, dust-free working environment. And unfortunately, we know that's gotten worse in recent years instead of better. Another way to put it is, just as all cirrhosis is not caused by alcohol,
yes,
all COPD is not caused by tobacco smoking. A lot is, but not all. And sometimes our bias is that if they have COPD, that it's the patient's fault.
Right.
And that's not always true.
So what suggestions do you have for rural health providers? What do rural health providers need to do better?
Well, I've got my list.
Okay.
and what I have, and so one thing I thought about is when we say rural health providers, thinking about who your potential audience is for this interview, that there's kind of two kind of providers. There's the hospitals and the clinics who are sometimes referred to as providers, and I think that those hospitals and clinics who have not only CEOs, but frequently medical directors and staff presidents and leaders, I think it's really important that the hospitals be offering and supporting pulmonary and cardiac rehabilitation in their facilities. And I'm especially thinking of rural hospitals. We think that rural hospitals, critical access hospitals especially, can do this in a sustainable way. They have CME schedules and they have staff meetings. And so bringing it to the attention of their staff that these services are available, to encourage their staff to be using the pulmonary function testing services that they're providing. And we know that there's a big problem of primary care providers, internists, not referring their patients for spirometry and not referring their patients for pulmonary rehab. Pulmonary rehab is still so rare that it's just not in the front of the consciousness of the busy primary care provider or even busy internist. And so the hospitals and the health centers can take a lot of leadership, and the medical group practice medical directors and leaders can do a lot to make primary care physicians aware of the benefits of pulmonary rehabilitation and of the need to refer patients. We know of programs that have set up pulmonary rehab. The patients are all around, but they're not getting the referrals. And hospital and organizational providers can take the lead on that. Individual clinicians learn about the GOLD guidelines, learn about the ATS guidelines for COPD, get together with colleagues or practice partners and study them, figure out systems to put them into practice in your practice. Simple one is have the nurse look and see if this patient who's on 2 or 3 inhalers has ever had a spirometry that we can find in the record. And if not, set it up. The nurses can't do it as part of check-in. It takes too much time. It takes too much attention. It's too much of an interruption to patient flow. It's a lot harder than taking a blood pressure. And then the other thing is to be sure yourself as a provider that you're ordering spirometry on your patients. Refer your patients for pulmonary rehabilitation if it's available. And if it isn't, ask your hospital to make it available. There's a couple other things we haven't talked about. And that is basically what that is building prevention into your practice. And I want to say something about that.
Okay.
2 ways. One, we know that in standard primary care practice, occupational history and environmental exposures are frequently ignored in the medical history. We really need to do better as primary care providers, family physicians, at including occupational history. What work do you do? Do you have any exposures to dust or fumes? What are those? Where do you live? Do you have exposures to dust or fumes? What are those? We're pretty good at taking a smoking history now, offering people smoking cessation. There's been tons of education from the feds and everybody about that. But what we haven't been doing, and that I'm a huge advocate for doing, is working with youth, especially middle school and high school kids, at preventing first use of tobacco. And we now know that they're not smoking, they're vaping. And so a big thing for us is putting some of our attention in our pulmonary rehab sites here into having respiratory therapists and providers actually working with schools and school-based health centers to provide from 5th grade on information to empower kids to choose to never start using tobacco products in the first place. It's a lot easier to not start than it is to quit.
Absolutely.
So those are some of the things that that's my list of what can organizational providers do and individual practitioner providers do.
Yes, and I'm glad you added that in, the information about prevention from the get-go. That's important as well, so thank you. Can you talk about the COPD National Action Plan?
Sure. So I think it started around 2016, I think, the NHLBI, which is National Heart, Lung, Blood Institute, held I think they called it a national town meeting, where they tried to get a lot of stakeholders together and come up with some sort of guideline or plan to address COPD. And they went through a long process. I wasn't part of that. And in 2017, it was done. And in 2018, they actually published the COPD National Action Plan. And the COPD National Action Plan is organized around 5 main goals. Of those 5 main goals, the second one is improving care for patients in general. The first one has to do with empowering patients. Second one has to do with primary care. There's another one about keeping statistics, another one about research. But each one of these goals has 20 or 30 sub-goals. And so the one that I find is most relevant for us is the second goal about improving care for patients. And there is a major part of that that's about making pulmonary rehabilitation more available, making quality assured spirometry more available, especially in low access areas. There's definitely an emphasis there on rural areas. So having that as kind of a national, we would like to consensus among stakeholders has been very helpful. It helps to talk to hospital staffs. It helps to talk to medical societies. It helps to talk to practices as something from a high prestige organization, national organization, United States organization, about the need for this and about how to go about it. And I've found it useful. And it's 68 pages, so you have to take some time down and really digest it.
Yes.
But it's worth it.
Yeah, good. Thanks for zeroing in on improving care in that scenario. You've seen a lot of things in the 41 years you've been a physician in West Virginia, plus the rest of your life experiences. What scares you the most about the future of COPD care? Well,
you and I talked about these questions, and so I did have some time to think about this ahead. And, I decided that what scares me most, and I kind of want to go back to the broader primary care perspective, and this might kind of be surprising to you, but what scares me most is the incredible growing income inequality in our country. Because people in rural areas tend to be older, poorer, and sicker than the population as a whole. And I think, especially with the educated audience that you have for this podcast, people are pretty aware of what we're experiencing in this country in terms of income inequality, and that the gap is getting bigger and bigger. And that has an impact on healthcare, because efforts to make healthcare available to everyone are very much influenced by the political process. And as the income inequality gets greater and greater, it's harder and harder to get things for the 50% of the people at the bottom. Right now, we still have over 20 million. Let's see, I think as of 2018, 9% of the population, 28 million people without any healthcare coverage. And that's all part of the political process. So that my answer is growing income inequality, and that affects all healthcare, including COPD, which again is the fourth leading cause of death in the United States, tremendous disability and suffering. To deliver the things that we want to deliver to people, everybody has to have access to care, and that includes healthcare coverage.
Great. Thank you for sharing that with us. So let's flip that question around. What gives you hope?
Well, I mean, it almost is flipping it around. What gives me hope in terms of that big picture is that the idea of Medicare for all, or basically healthcare coverage, good healthcare coverage for everyone as a national priority, has gone from being a crazy radical idea to something that's being actively talked about a lot more than it had been. And I know that we're not going to get that with this Congress or this administration, but the fact that people are talking about it as a possibility gives me hope, because every day when I spend all kinds of time working on improving care for a specific set of people, whether it be COPD, coal miners, people with diabetes, adolescents who are at risk for all kinds of healthcare problems, always in the back of my mind, I have, but what about the people who can't even get in, or who don't come at all because they can't afford the deductibles or they can't afford the medicine? And so to me, that's a major thing that we need to address as a society. And it gives me hope that it's being discussed more than it was.
Yes, thank you. So it's hard to believe, Dan, we've covered a lot of territory in the short time we've been talking here today. If our listeners only take one thing away from our conversation today, what should that be?
I would say that if you take one thing away from this conversation, I bring it back to the disparity between what's been happening with all of the other chronic diseases in our the five leading causes of premature mortality, preventable mortality in the country, which are cancer, cardiovascular disease, accidental injuries, COPD, diabetes, that everything is getting better. There's a gap between rural and urban. I mean, urban is more better than rural, but they're all getting better except one, and that's COPD. And with COPD, the prevalence is going up in rural areas while it's going down in urban. So I would say that it really does make sense for those of us, especially who work in critical access hospitals, rural health centers, to really pay more attention to COPD than we have, and to spread out from our traditional narrow focus on prescribing tests and drugs to prescribing rehabilitation on the sick end, and to providing primary prevention to our youth on the healthy prevention end.
Dr. Dan Doyle, physician and so much more. Thank you for joining us today and sharing your perspective and your expertise on access to care, as well as COPD in particular in rural America.
Thank you, Bill. Thanks for giving me this opportunity to get my ideas out there.
Thank you all for listening. If you enjoyed today's episode, please go to iTunes, Stitcher, Google Play, whatever your favorite podcast app might be, and subscribe to Rural Health Leadership Radio. If you'd like to continue the conversation of leadership in rural health, you can also join our LinkedIn group called Rural Health Leadership Radio. And while you're on Facebook today, give us a like. Yes, check out Rural Health Leadership Radio's Facebook page, and we always love likes. Until next week, let's keep working to improve rural health, one conversation at a time.
If you would like to connect with today's guest, please send an email with your contact information to bill@billoxier.com. If you would like to be a guest or suggest someone else as a guest, have a question you would like to ask, or simply want to contact Rural Health Leadership Radio, please use that same email address, bill@billoxier.com. That's BILL@BILLAUXIER.com. You can also visit our website at www.rhlradio.com.
And we'd ask that you please support our sponsor, the Dynamic Leadership Academy for Rural Health. The Dynamic Leadership Academy for Rural Health's mission is to improve rural health one leader